Yeah, welcome everybody. Thanks for coming along. Some of you are new to this forum. I think we run it every couple of months, and we at interRAI Australia are promoting the use of interRAI toolsets in the Australian context, and there are plenty of opportunities for that to happen in the next little while, next couple of years, and we obviously advocate strongly in wherever we can in the industry, also in the Department of Health and aged care, and we're quite involved in quite a lot of discussions around that idea. I and a number of my colleagues also involved very heavily in activities with interRAI internationally, and so we have a pretty good idea of what goes on in other jurisdictions with regard to assessment systems and particularly interRAI systems. And before I say anything more, I'd like to acknowledge the traditional owners of the lands upon which each of us live and work, and pay our respects to elders past, present and emerging. In so doing, interRAI is very conscious of Indigenous people, and in many jurisdictions has designed its tools to accommodate the special needs of such groups, and that's particularly the case in countries like Canada. And if interRAI should come to Australia, we'll be attending to those groups in the same manner. Just a little bit of news. We've got a couple of pieces of work that we've done recently that will be distributed sometime soon. One is examining the relationship between interRAI and the SNOMED CT data terminology system. There is a paper which has been prepared, which we're going to circulate shortly, and also we're going to have a publication in a journal, hopefully in the near future. The relevance of that is quite important because SNOMED is the terminology system that is pervasive in the hospital sector and also in primary care to some extent internationally, and it has a very big footprint. And so being able to translate or marry interRAI assessment data items to SNOMED is quite important from a strategic point of view. We've also done some work recently, I think we've mentioned this before, to attempt to map the interRAI assessments, the ANAC case mix system that's used in Australia, and we think that could be mapped pretty accurately should the need arise in the future. That paper will be released at some point in the future. Internationally, I'm aware that the state of Alaska in the US has just signed a contract with interRAI to implement a number of tools, including the interRAI home care. And they're an interesting jurisdiction in the sense that they have a very disparate population, Indigenous populations, and also, big issues around distance and access because of inclement weather. We have a similar kind of problem here, except here it's hot weather and desert. There it's snow and ice and the like. But I'm in discussions with folks in Alaska to come to this forum sometime in the near future to tell us about why they've adopted interRAI and how they're going about it. And I think we could learn something from them. So that's something to look forward to in the near future. There's also quite a bit of development in residential care in Switzerland, where there is a move, there's a potential mandation of the interRAI long-term care facility system across Switzerland, and that's fairly likely to happen in the next year or two, pending government decisions. They also have a extensive use of the interRAI home care and the checkup tool for simple assessments. So I'll keep you informed of anything interesting that happens there. Maybe we can get somebody from Switzerland to talk to us sometime in the near future. We have had a talk a couple of years ago, but they've got more things to tell us now. So that's enough of me. I'm going to now introduce Meagan Snewin, who works for the Digital Health CRC, where she's a program manager. She's got a background in IT. Her CV says that she worked for IBM for a long time. Happily, perhaps, I don't know, but she's certainly been a great friend and tremendous help with our project at UQ. the ACDC, or Aged Care Data Compare project, which has had an intersection with interRAI systems all the way along, and she might say something about that. But she's going to tell us something about the Digital Health CRC, particularly about how it's been cultivating a move towards standardisation of functional assessments, which are really what interRAI is about. So I'll hand over to Meagan, and then subsequently Tim Blake will kind of follow shortly thereafter. Okay, Meagan, the floor is yours.
Thank you. Absolutely delighted to be here today, to be introduced like that. My name's Meagan Snewin, as Len said. I have been working at the Digital Health CRC for 4 years now, and at the Digital Health CRC, aged care is a top priority of ours, and I'll talk a bit about that today. Prior to that, Len did say I had worked for IBM for 14 years, actually. It seems like a lifetime ago, but when I did work at IBM, I worked in digital transformation in government health and human services. So worked on a large program of work in Queensland and Singapore, and a lot of in New Zealand as well. So in some of the countries that interRAI has been implemented as well. So have a pretty good understanding of this sector. Was happy times at IBM, although I think I'm happy with where I am here at the Digital Health CRC. So I've worked with the team at UQ on a number of projects, and we've got some other people on the call from Regis, and I'll talk a bit about the work that we've done there. Joining me today, Tim Blake, who is an advisor of ours and working with us at the Digital Health CRC. So just to give people a little bit of a background into the Digital Health CRC, and I won't spend too much time on this, but what we do is we are a collaborative research centre, and we are funded, that program is funded out of the Department of Industry, Science and Resources. It's a 7-year not-for-profit organisation. We bring together industry, academia and research to accelerate the translation of that research and put it through its paces and create an evidence base, which we hope to move into translate the findings and have impact, and or into the commercialisation arena to address sector challenges. We've been working in the aged care space since the beginning. The Aged Care Data Compare was one of the flagship programs that we stood up pretty much from day one, working with UQ and partners, BUPA originally. The Department of Health and Aged Care, now known as Department of Health, Disability and Ageing, has been there since the beginning, have been following along and very entrenched in this program of work, the Aged Care Data Compare. It's been running for a significant amount of time. We've seen at the same time a significant amount of reform happen in aged care, which has meant many challenges and changes for aged care providers. So with this in mind, and with the original Royal Commission that was issued, we're still working towards fixing some of those issues. So our aim at the Digital Health CRC is to support the rapid transformation of aged care. We do that with these research projects, but we also do that by providing the insights through government that we have coming out of these research projects. And we're hoping that we do that with the wrap-up of ACDC happening in June to address some of the issues that we've seen in trying to improve quality using better data to inform that care standards and support decisions making. So moving on from this side, what did we see when we started ACDC, the first research project? This is probably not new to any of you. There was a lack of data standardization. There still is a lack. This is what we started with 4 or 5 years ago. There's still a lack of national minimum aged care minimum data set, and there is no mandated functional assessment. So what did we do as part of ACDC? So for part of the first project, we created the development of HL7 and 5 data exchange between and created a data and analytics platform. We had UQ team ran a very robust industry subject engagement piece where they created quality indicators. And then in the second phase of ACDC, what we've done is we've hardened all those artifacts and worked with Regis and their aged care provider, their clinical information provider, Autumn Care, to trial a couple of different pieces of software that we've created. So one is an aged care quality indicator app, which is using the de facto standard of interRAI as a questionnaire and an instrument, working with the Autumn Care data and generating quality indicators at the point of care, and then a BI dashboard as well, which is helping the Regis staff internally look at their quality across their benchmarking across their different facilities and comparing to one another. We got so far with the Aged Care Data Compare project. As with any research project, there is always a gap between the end of the project and how we see things going on to transform and have impact and scale. What we ended up doing at the end of late last year is we commissioned a report by Semantic Consulting, and this is really to provide some analysis of the one issue that still remained, which is even if we have all of these good things to collect the data, unless the data is standardized underneath, so unless there's a minimum data set and an associated functional assessment framework, then it will be extremely hard to transform aged care in Australia. So to remedy this, we commissioned Semantic Consulting, and we asked them to do a couple of things. So in the event that Australia should look at a standardised assessment system, we think that interRAI is the only obvious choice, backed with evidence and implemented in many different countries around the world. We commissioned Semantic to do a report on what it would take to technically implement such a standard from lots of different angles. So if the decision's made by government on a functional assessment framework, what would it take to implement? So, you know, we appreciate that the aged care sector is just drinking from a tap in terms of the level of change that's going on. You know, disrupting it with the change of functional, should a mandate be brought in, the change of assessment framework, that would be a massive thing for them. So how would they go about it? What does it look like? And what were the things that would need to be considered by the government in order to make that work? Here's a link to the report that Tim is going to talk about. We launched this report just in time for ITAC conference this year. We also commissioned another report called the Aged Care Data Landscape, and you can imagine what that's about. That highlights the complexity and fragmentation and duplication of data and lack of standardisation of tools and data requirements across the sector as well. So a lot of these reports call for the standardisation of data and assessment in aged care, which will allow the interoperability and to move data between settings, like Len suggested earlier.
Tim, just by way of introduction, Tim's the Managing Director of Semantic Consulting. And I think reading his bio, I would call him a health informatician and an IT specialist, but many other things. And he's worked in many kind of activities inside and outside of Australia, but he's led a very productive consulting company for more than a decade, and he's been very successful at what he does. According to Semantic's website, they provide frank and fearless advice. And my experience of Tim is that he does just that, but he does it in a gentlemanly and thoughtful way. And so he's a very useful character to know and to seek advice from. So with that introduction, Tim's going to tell us about the work they did to consider the possibilities around interRAI and Australia. So thank you, Tim.
Thanks, Len. That's very kind. So the piece of work that we were engaged to do, yes, was to kind of explore what it would take to implement interRAI systemically in Australia. We considered that to be a socio-technical problem, not just a technical problem. There are a range of complex interweaving things around change and incentives and motives and politics that need to be considered as you think about something like this. It's not just a technical problem, although the technical problem is not insubstantial either. The first thing we sought to do was really just to understand the current environment when it comes to functional assessment. And some of you, if you work in aged care, may understand this as well, or even better than we do. But to confirm the fact that, the way we do functional assessment in aged care is an absolute mess. Effectively, each vendor implements their own bespoke system for functional assessment, which is then often further tailored by clinicians within aged care providers, resulting in, I suspect, tens or hundreds of different ways of doing this, none of which have underpinning them any kind of common data set, any common set of data definitions. And in fact, if you zoom out and look at the entire data life cycle for aged care, we just haven't had that vision for a common set of data that underpins everything from entry into aged care through to quality improvement, reporting back to government. Every single stage of that is disconnected in terms of its data definitions. So it's a problem, and just to give you a few facts, I suspect you guys know most of these already, but in Australia we're dealing with over 2,600 residential aged care facilities, 760 aged care providers, probably 260,000 older Australians receiving home care packages, although it is a relatively green field from a systems perspective. We're overserved in terms of systems providers. So we have more than 10 aged care system providers, which also means that they're all very small, generally speaking, with a couple of exceptions, and therefore investing in research and development is not high on their agenda because there isn't a lot of budget for that. In terms of thinking about this as a socio-technical problem, that is a material factor to bear in mind as we think this through. We have an emergent national minimum data set, but it's important to determine what that actually means. So we have had the department work with the Australian Institute of Health and Welfare to describe an absolutely minimal set of common data items. But with the AIHW lens, the primary purpose for them is secondary use and analytics, not necessarily use at the point of care. And I think this is one of the things we need to bear in mind as we move forward. It's great that AIHW is massively on board with interRAI, and the CEO of AIHW is massively on board with wanting to use interRAI because they do not, quite rightly, they do not want to create a standard from the ground up. But their lens is very much a secondary use lens, and that's interesting, but I don't want a world where we have interRAI used in secondary use and we have to have 1,000 different mappings into interRAI from inadequate point of care systems. Success here is really getting interRAI injected into use at the point of care. So that's something we still have some work to do on. So we saw throughout the consultation process really to understand the perspectives of different groups, to try and formally document the use of interRAI in other countries, where a number of countries where that is seen as very successful, notably Canada in particular, where they've done some really great things in that space. And then look at what are some of the options for implementing interRAI on a system-wide, systemic basis across Australia, which, given the technology landscape, is more complex than it may seem, particularly, again, given the context, which, while we were doing the report, was a rush to July the 1st, now has been postponed a little to November, but the reality remains a lot of providers and vendors are absolutely overloaded, and we're not willing to talk about adding other things to their lists of things to do. But if we back up, I think even just understanding whether people have a common view, a common strategy, a common way of articulating the value of a standardized functional assessment system, I think there's still some deficiency there. We found a handful of people who really do understand that, a couple in government, but there is still a need really to push that understanding of what is the value of doing this. And the competition, and then maybe we can discuss this a little later, is probably less some other system than it is we want to build this ourselves, because we don't understand A, how complex it is, or B, the value of the countless research that's gone into developing interRAI as a system. So that forever, I think, remains our challenge, people not understanding the magnitude of the work required to do something in this space, and the complexity of standardizing that. So, I mean, I think a lot of these statements here are pretty self-explanatory. The desire, and this is stated in the aged care data and digital strategy, is that we want to move to kind of collect once, use many times. But I just want to pause for a moment and talk about how bad this is in aged care. I've done a lot of work in healthcare, and healthcare is pretty bad, but aged care is worse. And we seem to have this barrier between every single step of care not being able to share with other steps of care, to the point where, the ANAC tools and IAT, the only way that those can get embedded into later processes is as non-computerized PDF forms. Nothing gathered from that entry process into aged care can be actually shared at an atomic level into the systems, partly because they don't gather the data in the same forms, but partly because government doesn't want people to do it either. But on the other hand, and here is the cognitive dissonance, we have aged care, which is highly stressed, has a workforce that is under massive pressure, and yet we sort of insist on these things that are unhelpful for us. It's almost like we're voting for our own abuse. The lack of data standards means that we don't then make life easy for a workforce. And so when that workforce wants to move between aged care facilities, they have to relearn ways of doing functional assessment. It's different everywhere. We can't move the data around because it's different everywhere. Yeah, I think before we think about solving this problem, we sort of have to admit how bad it is, and the impacts. And we constantly talk about the workforce crisis in aged care. That is not totally, but is partly a product of the way that we have designed our systems over time. And we have to articulate that there's no quick fix here, but moving towards a solution in this space will ease some of the pressure on some of those other problems that don't, at first view, appear to be technical problems. So these are some of the things that we heard through the consultation process, and very happy to take questions on them or to discuss any of them further. I kind of alluded to this, but I think there was generally a sense that people have heard of interRAI, that they sort of generally saw it as a good thing, but very few people could articulate what was the value of interRAI. And you'll see reflected in the recommendations that we made, I think, the need for just an ongoing campaign of articulating that value so that people can really be able to articulate it to their own stakeholders within their own contexts. I think the idea of a standardized functional assessment lands well, but it's the age-old change problem of everyone wants change, but no one wants to do the change themselves. And so part of what you're going to hear later as we talk a bit about crafting up a new kind of generation of ACDC project, the son of ACDC, if you like, is really trying to break some of that nexus of nobody actually wants to go to the work of doing this implementation themselves, but once they see the benefit of it, I think it will become more self-explanatory, and we'll actually start to get some traction. The question that's been in our mind the whole time, and again, you'll see this in the recommendations that we've made, but is how do you get change in a field without government mandating it? We've sort of become this sector where we only do things because government says we have to, and then we're so caught up in the volume of work, particularly following the Royal Commission and everything that has flowed out and everything that now needs to be done by the beginning of November. How do we create the sense that some of these things just are intrinsically the right thing to do and should be done for the sake of strategy and value, not just because we'll get whacked if we don't do them? Because if we are constantly only reacting to extrinsic motivation of reward or punishment for implementing government mandated things, we risk not doing them well. and we risk not understanding why we're doing them. And so that leaves this question of how do we get people to think about doing something like interRAI's long-term, LTCF form, and the value that's derived from that, but in a way that's not just because government has told them to do it. And that's the tension that I think we're living in here. As I said with the third point here, the development priorities for providers, some of them partially get it, but the argument, and remember this consultation was probably done 3 months ago now, was, yeah, okay, we're interested in thinking about it, but not at the moment. It's not on our dance card. So, and we've probably sort of maybe slightly softened the way we think about the fourth point here. We do think a government mandate is ultimately required, but we want a government mandate to be in the context of people seeing the deep value of doing this stuff for its own sake, not just because they're told to do it. But it is a big technical change because it goes to the way that software providers store data underneath their systems, and that can be potentially a big re-architecture of their systems in order to do this. So that may be a topic that's worthy of some discussion, Len. What we also wanted to avoid, and the history, certainly in the medical space, in the health space where I've done more work, is when government asks people, software vendors, to make changes. We've created almost a Pavlovian conditioning where those vendors will, start dribbling and hold up their hands and expect cash to appear. When you have 10 or more of those vendors, the prospect of mandating something and then expecting them all to come back and say, well, sure, you're going to pay us $250,000 or $500,000 to do that, very quickly government starts to back away from that. And we're seeing that in the health space as well. Government wanting people to adhere to standards just in order to play in the industry, not funding them. But the history of the My Health record has very much been paying vendors to do stuff. And as I said, with those kind of extrinsic rewards, when you pay for a behavior, you often get lowest common denominator compliance, and people don't necessarily do a good job of it. When we're considering, 10 different vendors implementing LTCF or the home care assessment as well, what we don't want is 10 people doing that badly all at the same time, massively stressing the resources of interRAI Australia to be able to support them in doing that implementation. So that's something that requires some careful thought. We also noted, although I don't actually think this is as big a point as it potentially sounds, but we noted that there was concern amongst some stakeholders about intellectual property and royalties and the way that interRAI looks, makes some money to cover its costs. I think a lot of that was probably fear, uncertainty, and doubt that might have been sown by various people who were against interRAI at various stages, and I don't think there was much substance to it. But it's interesting how some of those things can spread a little. So we have come across those views and tried to water them down and actually ask people what they mean. And sometimes it's quite instructive when you ask that people don't actually have any detail. It's just a headline. I think finally, and Len can probably speak to this more in the discussion, but we noted there's some work potentially, given that we have a standards process in Australia that's quite active at the moment in the healthcare space, that's starting to dip its toe into the aged care sector. Some of you may have heard of the Sparked Fire Accelerator. That's what I'm referring to here. In order to achieve alignment between interRAI, which is let's maybe call it a de facto standard, it doesn't necessarily in Australia have a national standard status, but it may be a de facto status. But there are some points of integration that we'd need to achieve in order for it to be considered on that national standard stage. And one of those is, some integration points with SNOMED CT. That doesn't necessarily mean we need to replace the way that interRAI does its own clinical terminology and coding, but there would have to be some mappings and some clarity brought to that space. And I know Len's done a bunch of thinking, and I know that it's a complicated problem, both technically and politically. Apologies if this is a little small to read, but so we've talked a bit about the consultation. This is where we landed essentially in our thinking about what is possible, and let me try and talk you through it. So we really saw what might be possible as a decision tree rather than a series of just mutually exclusive options. because we're trying to guide government and other stakeholders through what is it that you actually want to achieve, what is the extent of the vision that you want to have here. And the first question is really, do we want to keep doing what we're doing today, which results in fragmentation with all of its consequences downstream, or do we actually want to achieve some kind of common set of data items across the aged care life cycle? If the answer to that is yes, we do want to achieve that, how can we do that? And there's two fundamental ways we can go at that point. We can either go, we're going to build it ourselves, or we're going to adopt an existing asset that has done this, recognizing how complex this is. So this is a major decision point here. Now, if you go down the path of we're going to do it ourselves, you could develop those bespoke data items, but just for their own sake, or you could develop them as well in option 3 for use in a standardized functional assessment system. The reason a couple of these options are in grey, not in dark blue, is because we believe they're logically possible, but they really are not delivering any significant value. So we've tried to de-emphasize them. If, however, you go down the other path of adopting an existing asset, well, you have to decide, well, what kind of asset is that going to be? Are we going to adopt interRAI or some potential competitor here? And so we end up in terms of option 5 or option 6 and this assessment was actually undertaken in Belgium prior to their implementation of interRAI. They looked at a range of different options in this space and arrived at effectively option 6, which is they were going to implement interRAI nationally. So the way we've laid this out was really trying to help government think about this decision process. What is it that you want to achieve? And effectively, the decisions that you could arrive at became the leaf nodes of these questions that we were asking. I'm happy to discuss this a little more in the discussion. And look, I think this stuff is, again, relatively self-evident in terms of what are the benefits of doing this. What I did want to comment on, though, was we've sort of created this sense in Australia that QI reporting to government is some kind of end in itself. And then we're surprised that aged care providers aren't excited about that or moving towards that really quickly. But effectively what has happened, and forgive me for being frank and fearless, Len, but the aged care division has built their GPMS system, which has B2G APIs for an automated mechanism for submitting QI data. But they then have realized we've done that probably 3, 4, 5 years ahead of the aged care providers' ability to submit that data in that way. So they're kind of then a little surprised that they're still getting data submitted to them in spreadsheets. So one of the things that I suppose we noticed during this process is very few aged care providers seem to have a deep notion of what we would call a clinical quality improvement feedback loop. The idea that we do this quality reporting should first and foremost be for us as a provider so that we can improve the quality of the service that we provide, so that we can be vigilant, so that we can do assessment of our own quality and safety. And that ultimately that government reporting should be a side effect or a byproduct, if you like, of that process that already exists. But because we don't have that sense today of, doing that inherently for its own sake, therefore QI reporting to government becomes a massive impost because it's not something we've designed into our systems as they exist today. And that seems like a small observation, but I think it's quite important because if we want to motivate aged care providers to do well, to be better, then I think getting them doing some of this stuff for their own sake is actually one of the key ways that we can provide that motivation. Look, all of these other benefits are absolutely true. I think we massively assist the workforce if we move towards this, noting that it will be a long journey to get there. QI reporting becomes easier because it's a byproduct of a process that we want to do. And we can start to do things like pre-populating data because, hey, when we do a functional assessment, we typically actually already hold quite a large proportion of that data. We should not be requiring that an already stressed workforce who's having to rekey that data every single time we do something and then be surprised that aged care is often the mess that it is. I mean, I'll start this conversation, Meagan, and then you can kind of jump back in. But off the back of the recommendations in the report, which you can go and read for yourself if you want to, we've really kind of conceived of a new project to begin to try and demonstrate some of these things tangibly to government. I think another thing that we've noticed is it's easy for some of us who have been working in this space for a long time to have a conceptual conversation and quite quickly grasp some of the ideas that we're talking about. It's sometimes evident, though, that in talking to government, we have cross purposes conversations because we're not necessarily conceptualizing the same thing. And therefore, an approach of show me rather than assume we're having the same conversation is quite important. And we are looking now to work with a group of aged care providers and potentially a number of vendors as well to implement the LTCF as a Smart on Fire app so that we can both implement interRAI, but without getting the vendor to have to do it themselves. So it will be implemented once, integrated into aged care software. The aged care software providers will need to make slight adjustments to be able to support running Smart on Fire apps, but it's a relatively manageable change. But in doing so, they will build a capability that can be used beyond the life of just this project. But this is a means to distribute this capability to those vendors very quickly, and we hope even prior to a government mandate, which may one day come, we can get vendors going, hey, look, this is really good. And then one of the other things we want to show is that using LTCF as a generator of functional assessment, potentially one that could slowly or quickly replace the way that it's being done within aged care providers, the system that we want to build will also have a way of aggregating that information, mapping it, and I appreciate there's some complexity in this, but mapping it into the forms that the B2G API wants to receive, and actually demonstrating the ability to automatically, with an approval process, of course, but to submit that data to a B2G API, thus not only demonstrating LTCF in action within Australian aged care providers, but also ticking off a major job that has been stressing many of them, and ticking the box of government who want more people to use the API that they've built. So we've tried within the scope of what we're doing here to build a project that actually has value for a whole range of different stakeholders. There's a number of complexities in achieving that, but that's the intent behind what we're doing. And I think Meagan and I are very happy to discuss that further. But I'll hand back to you, Meagan, to kind of say some additional things about the project.
Yeah, thank you. I think one of the key things that we're trying to do, as you mentioned, Tim, is bring vendors and their associated aged care providers on this journey with us to deliver. And the reason we're trying to do that is to get some groundswell, so we don't have that just that intrinsic motivation to do something that we've got, that we're creating value for that group of people to see the value in it and to move towards it. I think with the B2G reporting, there is a technical mechanism now, and so some organisations do provide it to send data in that way, but it's not grounded from a standard assessment base, and in that quality improvement, the continuous quality improvement loop. And I think we've got some people on Regis from the call today, and maybe we can get a comment from Sarah or someone about the way how we aligned that. So the sending of the data to the B2G should just be the end of what is already a primary process in the organisation. So yeah, we want to use this as a demonstration to government about what is possible, using what we've done out of the ACDC projects to date. So we're not building from scratch, we're reusing, we're building on Smart on Fire, so the latest standards, looking to leverage build once, use many times, same as the same mantra that we have for data. So yeah, I suppose where to now, Len? You want to open for questions or?
Well, I'll just make it brief and then we'll open it up for discussion. So this is a very exciting idea and tremendous that the CRC is taking this on. It's very exciting for interRAI in Australia, but also for the world, because interRAI has some challenges. One is that the data elements need to be presented in a particular configuration to the clinician who's recording information. The Smart on Fire app creates that standard, and it looks like it's sitting inside a bespoke software solution owned by somebody, but it in fact retains the integrity and precision that you expect with an interRAI item. The second big problem interRAI has is calculation of the applications, all the scales and risk screeners and the caps and all those things that are the critical byproducts. If that's done in an app once, and that gets embedded in every software solution, we can be absolutely sure that that code is accurate and produces perfectly compliant outputs. And rather than, and I've had lots of experiences, multiple vendors who are not particularly good at writing complex code end up producing different results with the same data. This solves that problem. And third, it creates so all the applications can be calculated inside the app and then presented back into the software, the parent software environment as scales and whatever, knowing that so the vendor doesn't have to worry about accuracy. They just have to figure out how to present that to clinicians and administrators. Sally.
Yes, hi, Tim and Meagan. Thank you very much. Sally here from interRAI New Zealand. And just to say that we've had interRAI mandated in aged residential care for about 10 years now. And the positives, of course, are the benchmarking, care planning, all the positives that we all know. But there is, because it's mandated, there is that little bit of negative narrative that it's a tick box exercise, which you'll be aware of, and that's a big one to stamp down early, just as a heads up.
Yeah, look, I think a risk of repeating myself, we have these two approaches, right? The government mandate versus the inherent sense that I want to do this because it adds value to my business. And we need to keep stressing this, like you always have to mop up the tail of reluctant people with the mandate. But our view is, can we get some of the progressive providers and vendors to go, actually, we can see a lot of things that could differentiate our business if we did this. And then if you get the leading providers to do that, then you maybe get a group of followers who go, oh, why are those guys doing that? That's interesting. And you start to pull a group of people through. The remainder, you won't get them doing it come hell or high water, hence the government mandate discussion. But that's the dynamic we'd like to create. Is that going to work? I don't know yet. Well, we'll get back to you, but that's what we're aiming for.
Well, Sally, we definitely are using the use case that we've seen in New Zealand, that happened with Momentum as a use case of ours and a study. As we take the best and the bad, not the best and the worst of those things and learn from them, so that we can sort of leapfrog some of that, which is partly this initiative that we're doing. Probably should say also that we've got the interRAI team working with us through Len to evaluate what we're doing so that we do that aligned and sort of checked from a technical perspective. How do we go about engaging, using this product to engage with providers, like Regis, Sarah and the like, who are really at the forefront of what they're doing, to then feed back into initiatives that Ageing Australia are doing around industry benchmarking as well. So how do we sort of align all of those pieces of work in order to for the government to feel comfortable in making the right decision? It's complex. It's a lot of influencing, as well as the technical proof points that we need. There's a lot of work that has to go into the networking and stakeholder engagement piece, as you've described some of it, Sally.
One of the huge challenges, Tim, has been, and I know this is talking to folks in providers, find the interRAI solution very appealing, One problem is finding a software vendor that provides other capabilities alongside that, meets their expectations. The construction of a Smart on Fire app may obviate that problem. Then the problem becomes the risk of implementing a way of doing things that may run counter to what the government ultimately decides it wants. And so if the government, creates a large NDS of non-interRAI type, then there's a massive risk of duplication of effort. And so that makes, I think, the industry very risk averse. This has been the case ever since, I think, probably the aged care funding instrument was introduced. It became the de facto assessment tool, even though it's a case mix tool. Simply, all the effort was focused on getting the case mix right, and an assessment for care provision became a secondary consideration. And even though with the introduction of the ANAC, one of the objectives was to relieve the provider of burden of completing the ANAC, because it's done by external assessors, it hasn't opened the door to people using other than the kind of patched together bespoke solutions that you spoke about earlier. So that's kind of nub of the problem, as far as I can see, in terms of providers and the risk appetite they may have in the current environment. But be interested to hear if anyone online has got some perspectives from a provider point of view about that. I know one provider's here, but there may be others.
I'm happy to have a brief word, Len, being from Regis, and I will preface that this is my opinion. This is not Regis's opinion. Yeah. But within my role within Regis, I would love to heavily influence us to look at bringing interRAI into the way that we do our assessments and care planning, and almost be that first provider to uptake and pilot how you do that implementation stage. I drank the Kool-Aid back in March when I joined the workshop, and I think for me, having come from acute, I have an intensive care background. I'm used to do very, in-depth assessments and information being linked up. It seems a no-brainer that this is the way that we go, and somebody has to take the lead. Now, the board may not agree with me on that. They may want a little bit more information, but I would certainly love to see how I can positively influence in our space, because somebody has to, someone's got to give it a shot.
Yeah, look, it's really interesting to hear, and it backs up what we've heard before, that aged care providers get this value proposition far quicker than some other stakeholders. And let's be really frank, that this is often a discussion about where government is at in their understanding and thinking, because off the back of the Royal Commission, we've had a hell of a lot of activity and not much of it is super coordinated. And this is our challenge, right? We have to be able to articulate a couple of things. One is the absolute mess that we're creating by having completely bespoke functional assessment and the clinical risk that poses. And on the other hand, the benefits of moving to a standardized approach, the things we can start thinking about doing well and safely, like partial pre-population and creation of care plans, again, alleviating work for nursing staff and others. There's so many things that we can do well and safely once we have standardized data. But if we don't, then we run the risk of it being done 1,000 times, and some of them are good and some of them are bad. And I don't think people get that value proposition. We need to keep articulating it to government, is our point here.
And one of your points, Tim, that you made in that the transferable skills, you build up that RN workforce with understanding assessments, because I don't think they inherently do. I don't think they come out of universities understanding how to do it. But if you build it based on this, they can transition between providers in the sector, which is a huge workforce capability uplift that the workforce absolutely need. And to have a standardized functional assessment that they're all understanding could only improve the delivery of care across the board, which is what the government should be aiming for.
And I think the other thing it allows you to do, Sarah, is you have flexibility then with your provider, with your vendor system. And so if you do it in a smart on fire format, it can then be connected to Care or Telstra Health or Lead Care or whomever, but it then takes the onus away from each of the vendors going away and doing their particular thing, and like Tim said, circling back all the time with the hands out. We just take that away, and we provide the value to where the value is needed through the provider, who is responsible for doing all of the quality reporting and has all the regulatory constraints. And so I think it shifts the paradigm of I'm just saying, sort of like you're not then hardwired and connected in with one vendor. You've got that flexibility to do what works for your business. And I think that's an important thing for the sector transformation as well.
So you're thinking about the vendors, and I deal with vendors all over the world because I negotiate contracts with them for interRAI, but there's some fabulous vendors out there that make great use of interRAI capabilities, and the key thing about software vendors is, if they get even if they use the kernel of a smart on fire app to do the calculations and represent the data, there's massive opportunities for vendors to differentiate their products, because how they present that information to clinicians, how they organise it around their workflows, how they support handovers, how they make it easy for them to report, that's all dependent on the design creativity of the vendor, not the Smart on Fire app. Smart on Fire app is just it's like that kind of motor is somewhere under the bonnet, but the way the car looks and how it's driven and all that and how it represents itself to the driver is so critically dependent on the vendor. So I don't think this takes anything away from the role the vendor plays, which is absolutely critical. Chris, you just opened up, and Chris is from Civica, which provides software to New Zealand. Interested to hear what you think about it, Chris. We'll go a bit over.
Yeah, certainly. So, thank you for the presentation. I know, speaking from that vendor perspective in Civica, formerly known as Momentum, we're obviously prevalent in the interRAI space here in Canada with what we're doing in New Zealand. So I think as a takeaway, I'd love to understand who I could connect with to understand what contributions we might be able to provide in a pilot capacity, start unpicking some of this opportunity before there is a government mandate, because to your point, Len, I think that there is tremendous value that we can provide to the many stakeholders and work together on some of these initiatives.
Yeah, so I think you obviously can contact me, but Meagan is probably the touch point, and I'm sure she'd be delighted to hear from you.
Okay.
Absolutely delighted.
I've had a lot to do with colleagues in Civica for a long time, and they're one of our better. interRAI doesn't market companies, but it's one of the better providers, let me tell you. So, okay, we've gone over time. That was a really great discussion. Such a great idea, which I'm not going to take any credit for. I think this is Tim's and Meagan's baby, and it's a breath of fresh air in the discussions around how we might get through the door with interRAI in Australia. So thanks all for coming along, and particularly thank Tim and Meagan for their presentations, and we'll talk soon. Maybe I think the next talk might be about Alaska, because we're negotiating at the moment. That will be fun. Okay. Bye, everyone. For those of you listening to this conversation who may have further interests in interRAI systems, please visit our website, interRAI-au.org.